Every non-union of the clavicle should be operated?
Huh?
Do you think every non-union of the clavicle should be operated?
You mean the mid shaft?
Mid shaft?
Only when they are symptomatic. But in my experience,
most of the
99% of the cases I see are symptomatic.
They're symptomatic.
Symptomatic. They have much pain. I have seen some cases, oh doc, I have my shoulder is fine, I feel nothing, so I'm not operating the X-ray, okay? The majority of the patients that are symptomatic. And when they are
psychological pain, other than the actual pain.
Yes.
They don't have the actual pain, they have a psychological pain.
Okay.
Yeah.
Okay.
I think that should be treated for psychiatric treatment, actually giving them some antidepressants.
It's a matter of debate whether it's psychological. Definitely, if a fracture, clavicle does play a significant role in glenohumeral motion. We know that.
In upper limb motion.
Yes, but abduction, flexion, except rotations with arm by the side, it does play a role.
Sure.
If something is wrong, it may not have that much catastrophic effect, but it has to have some effect.
Sure.
To call them psychiatric or psycho, I don't think we are doing justice to them. There has to be something wrong in the biomechanics. Whether making that unite will take care of the pain is again open to debate. But yes, if we see something which is non-anatomical, which is something is wrong, and patient is having pain or symptomatic problem, after the patient has come to you, he has some problem.
Well,
nobody wants to waste money or waste his time just going to doctor's clinics.
Yeah.
So if he is coming to you, he has some problem.
Yeah.
Whether it is psychological, we don't.
But until proven contrary, you must believe in the patient's problem.
Good afternoon, everybody. I'm Dr. Debashish Chatterjee. I'm talking, delivering a lecture on behalf of Dr. Kanchan Bhattacharya.
I just had one question, if you don't mind.
Please.
In clavicle fractures, indications, has anything changed in the last 5 years? What is one thing which you say?
Shashank will come to that after this session.
Okay.
We have that. Okay. Okay. So I'm talking, delivering the lecture by one of our colleagues, Dr. Kanchan Bhattacharya, who could not come due to personal reasons. His topic was proximal humeral plating, when, how, and the nuances. The fracture in the proximal humerus, there is a difference between the two groups of patients, the younger ones and the elderly patients. In younger ones, you want to, number one, preserve the head and also to restore function. In elderly patients, it's of course alleviation of the pain is the primary thing, followed by the restoration of function. The indications of surgical fixation, of course, they are variable. Basically, you need to have a good alignment and anatomy. Classically, the 3 and 4 part fracture in the young, they are of course to be fixed. The 2, 3, 4 part fracture with dislocations, they need good fixation. And cases of split fracture of the head in young patients. And then some fractures in elderly, we'll talk about that. And there are more than one fixation options for any of these fractures, which we can debate on, and we have been already debating on. The 4 part head split fracture in elderly patients. There are different ways, but the proper reduction of the fracture is required. Everybody agrees on that. The good bone quality to maintain the stability is needed, because in elderly patients that is at times a problem. The fixed angle devices are an improvement over the non-locked screw plate construct, but they are not with their quota of problems. In young patients, the multifragmented or valgus impacted 4 part fracture is a definite indication for this fixation. The hemiarthroplasty is the last option, especially in case of young patients. So we must try to preserve the anatomy and the head as much as possible, mostly in young patients. The 2, 3 part fracture in younger patients, the locking plates do better. And they also do better in elderly patients in these sort of fractures, because you have a much better grip on the humeral head and on the shaft, and you are better able to maintain the alignment. In young patients, in all patients, when putting the plate, it is important to maintain the soft tissue alignment, especially of the rotator cuff, with suture fixation, which are taken through the plates. And all this has got a direct relationship, because the restoration anatomy has got a direct relationship between the humeral offset and the results. So you have to restore the tuberosities, you have to prevent the jutting out, especially of the greater tuberosity, because that will cause tension, impingement, and it will also have to maintain the tension of the rotator cuff. The stability of the fixation in young patients usually come from good reduction, and there is minimized devascularization of the fragments. You have to restore the cuff integrity, as you have mentioned, and the function. And AVN is a possibility, but it has been said that it does not necessarily lead to poor result. Now, the talk about the open reduction versus closed treatment for 3 and 4 part fractures and outcome. It has been shown that a properly reduced and closely reduced and fixed fragment, 3-4 part fracture, and an open reduction and fixation fracture, the functional outcome could be almost similar. The pain relief is also similar, but the key here is to get the good reduction and alignment by closed means. If you don't get it closed, then you have to do either a supplementary small incision, or you have to assort for the open reduction. So these are certain things with surgical plates and techniques he have put in. I don't know much about this. These are the technique things that he has put. The positioning, the placement of the plate, and the fixation outcome. The suture, the positioning that can be used is either beach chair or supine with a proximal radiolucent top with a towel under the scapular blade. The CM should come from the head end, and you should be able to see both the AP and laterals to do the job. The surgical approaches are usually deltopectoral, which is traditional or familiar, or some people can also use anterolateral acromial thing. The deltopectoral disadvantage are the difficulty in accessing the greater tuberosity fragment, which is commonly displaced proximally and posteriorly. Quite often you have to put your finger underneath to hook it down and plate it. But the deltopectoral overall is much easier approach, because we are more familiar with that. The anterolateral acromial approach is an incision from the anterolateral corner of the acromion distally down the shaft. The problem is you can access the greater tuberosity areas much nicely, but it is difficult if you have to extend it downwards because of the axillary nerve. And you have to, if you have to do that, then you have to identify the axillary nerve and do the job. For the fixation of the greater tuberosities, you have to pass the sutures through the calf tissues of both tuberosities, place them in the right places, and if you are using a plate, you can put them, we'll show that later, you can put them through the holes, proximal holes of the plate before you fix the plate in correct place. And this is very important. If you are putting an implant, don't leave it in varus. It must be correctly done, because if you are leaving it in varus, or if the plate is jutting out, that's not going to help. Use an elevator to lift the head if necessary, or you can use it with your finger, as just have been discussed before. And reduction valgus, that has to be avoided at all costs, and also the proximal jutting out of the plate. Periosteum elevator we said, and the sutures to the greater tuberosity and the lesser tuberosity to fix them to the plate or to the through the bone tunnels. Restore the retroversion if there is any still remaining, or you can use a joystick, K-wire or a Steinman pin to use as a joystick to control the head. Check the reduction in both AP and axillary lateral views, and then you put your plate and do these things. We talked about this use of elevators or the K-wires or the Steinman pin to elevate the head. use of KVS as joystick to hold the head in the right position. And other thing that has been mentioned is the preliminary holding of the head in right position and putting the shaft screws first before you go onto the head, because you have a chance to correct the varus if there is anything that is left of that. Then you can complete the fixation, put the supplementary screws, check your image, and you must have done your suture fixations before, suture passing through the plates beforehand, which were holding the tuberosities and the cuff, and then you can tie the soft tissues over that. AVN after plating is definitely a possibility. This is a case that has been demonstrated here, where the plates, implants have been reduced after 3 years, but you can see the degree of damage and everything, but still he is enjoying a reasonable range of movement. I think that's it really. The last few slides did not come. Yeah. Because last few slides did not come to me. It was mailed to me today, yesterday.
No, when he get a special gift for before time.
Yes.
Thank you very much. Any questions?
Any questions on that? Or do we move on to the next?
Just a comment about these plates.
Mhm.
I did a review for the journal on meta-analysis of all the papers published on the plate, and it's amazing that there is more than 50% complications with the plate and more than 45% of reoperation rate. And still, if I come to you and suggest this technique that's got such a complication and reoperation, you say, get out of my sight. But it's still, there's a big pressure from the industry to use these plates. And these plates, there's a place for these plates for non-unions or fractures that extend distally. But you have to be very careful because in the elderly, it will cut through that too rigid for this elderly bone. The best fixation is between the screw and the plate, where you want the best fixation between the screw and the bone. And therefore, there are a lot of them cutting out and collapse.
No, many a times I think we blame the implant, but actually the implant, there are various designs and design philosophies on these plates. The most important thing is to get your plate, not the plate to be played, but your reduction to be played.
Oh, definitely. No.
I would say the second most important point is to get your sutures onto the plate.
Sure.
And third, placing the plate correctly is very, very important, because if you lost the principal flaw in the design, it's too high. So that's why they've recently redesigned it, and it's a bit more low. But even the angle of attack of the screws are not, the best. I think one of the other companies have various designs, but there is still room for improvement.
And even the mobile of the screws.
So we are going for improvements on this, and we are still waiting for.
And also the choice of the patient is very important with bone quality. That's very important. Yeah.
Also, you said 45% reoperation rate. Did that include removal of the plate or just for?
Included removal of the plate, but removal of the plate for various reasons. Why
Not on impingement.
You don't need to for impingement, for different things.
45%.
don't think it's amazing.
I just want to make a comment. Me and my team, we have done many cases, and our reoperating rate is absolutely small. So my results are absolutely different. And why? Because first, reduction is the key. Second, I tie sutures on the posterior superior cuff, and I reattach these sutures not in the holes for the plate, but in holes that I do in the shaft. So this creates a tension band effect. And I guess that with a well-done reduction and with the correction of the medial hinge, results can be very good. I haven't seen such a higher rate of.
We have a very small.
But mine is very small.
Okay, so we'll go on to the next topic by Dr. Shekhar Srivastava on AC joint.
Now, yesterday we had a very lively discussion on AC joint injury, and we had some guidelines from there. Now, AC joint, as we see, is stabilized by this coracoclavicular ligament and the AC joint capsule. That's Okay, yeah. So the AC joint capsule, it prevents the anteroposterior translation, and the coracoclavicle ligament, it's a suspensory ligament of upper extremity, and it prevents the vertical translation of the clavicle. So these are the various modes of injury, and that is the classification. So type 1, there is injury to the AC joint capsule. Here there is sprain of the CC ligament. Here there is rupture of the CC ligaments and the clavicle goes up. Here it's goes posteriorly, the clavicle goes posteriorly, so there is damage to the CC ligament as well as it translates posteriorly.
Displacement.
Yeah, 3 is 100%.
No, 4. 4 is 100%. Displacement. Superior.
4 is posterior displacement. Posterior displacement, yeah. 5 is, there is also rupture of the trapezius and deltoid fascia, so it moves quite high. And this is the 6th, where there is subcoracoid displacement. Now the management protocol, there is no confusion about type 1 and 2. It's conservative. Type 3 is controversial, but most of the literature, they suggest early non-operative management and delayed surgery if required. Type 4, 5, 6, surgical option. So what's the non-operative management? Just manage in a sling, no Jones bandage or any strapping like that. Anti-inflammatory drugs, early range of motion, and exercises. Now the surgical procedures are many. So you had these Bosworth screws, hook plate, double button fixations, tight rope, Beaverton, and all that. Okay. So it can be either early or delayed, or anatomic or non-anatomic techniques. Now early surgery, you can go for repair of the CC ligament. Earlier there were these Bosworth screws and hook plate, and this flexible fixation with double button. Now as these requires removal of the implant, and also they prevented the movement of the shoulder joint, so they have now gone into disrepute. And there is also a place for reconstruction using the autografts. Okay. So this is one of the earlier case where we had this type 5 AC disruption. That was the X-ray, and this was managed with arthroscopic fixation. Okay. So here basically we are in the rotator interval, and okay. Okay. So here the cannula is in the rotator interval, and I am feeling the anterior labrum, and that is the tissue in the rotator interval. So all this was cleared so that the base of the coracoid can be exposed. Slightly. Okay. So there I am feeling the coracoid with my probe. And all the tissue was cleared with the help of a radio frequency probe. So your button has to sit right in the center and at the base of the coracoid, or else there is a high chance of fracture of the coracoid because of the pressure. Then the Arthrex tightrope device was used. The jig was placed over the clavicle around 1 centimeter from the AC joint, and the other end of the jig was at the base of the coracoid. So that is the guide wire over which it was drilled with a 4 millimeter drill bit. and the button was pushed through that. So there is a sleeve there through which you can push your button.
The shiver sleeve? But what are you using as a sleeve?
They have this sleeve in the system.
It
Comes in the system. Yeah. So you can pull it through the sleeve, or you can also push it. So these pulling sutures were pulled out through the enterosupe portal, and once the button was delivered into the joint, then the pulling sutures were removed. Okay, so it was tightened outside, and that is the final picture. Okay. So that's the jig. One end goes through the enterosupe portal, and here it is over the coracoid. Yeah. So that's the post-op picture. Okay. Now, delayed surgery, the indications are mostly pain, weakness, or deformities. And the surgical procedures are reduction of the AC joint and reconstruction using free graft or Weaver-Dunn procedure and Mumford procedure. So, in Weaver-Dunn, what we do, we basically take the CA ligament and detach it from the acromion and excise the lateral nasoclavicle and fix it here. And that is supplemented with a augmentation with sutures or graft. No, you don't need a graft because you are using a suture and you have already shifted the CA ligament from here to here. So that's another patient where we did Weaver-Dunn. It was an old chronic AC joint disruption, and they get very good range of motion. So, although the literature suggests that in type 3, there may be a benefit for early repair compared to delayed procedure, but still they are not very substantial. So, for practical purpose, we don't operate type 3 AC joints disruption. Only we keep a reserve for 4, 5, 6. So, type 1 and 2 AC joint injuries are treated conservatively. Type 3 is also treated non-operatively early, but delayed repair for type 3 in case of pain, weakness, or deformity. For 4, 5, 6, they are treated surgically. Thank you.
You finished before time. Thank you very much. So that was very clear. 1 to 3, no surgery. 4 to 6, operate most of them, or all of them. Would you like to comment? How do you differentiate between 3 and 4? On a general AP view, they all look similar to me.
You have to do the axillary view. Axillary view. Yes,
Which
yes.
many times you cannot
No,
do
for any shoulder, you have to have 2 views, just like any other bone,
So in
any other
most of
joint.
these acute patients, you cannot do axillary view.
No, you can do.
You do
You can do.
You ask the
Velpo view.
patient to
So we need to
bend
do
back
so.
and do that.
So does everybody know the Velpo view?
Yeah.
Would you like to tell them, Shekhar?
I'll show you the X-ray of this same patient, the lateral view.
When you're showing the X-ray, I think if you have a problem getting a Velpo view or other views, I think the one I would recommend is go and look for a strip view, STRIPP. This was described 50 years ago by a radiographer, and that gives you a better visualization of the glenoid femoral head with less radiation on the chest, and the chest wall doesn't come into the Initially, you put the
How is that done?
plate on the top and shoot to the bottom. So
What position is the patient?
the arm is always next to your chest. So it's very good, especially for fractures, because in the fracture situation, you don't know the version of your head many times. And that is very, very difficult.
Can you just show it on me? How do you do
It
it?
has a plate here.
Okay. And easy like this or like or just straight?
Slightly there.
Okay.
That's it.
Okay.
Go like
So
that.
almost like a Velpo view is almost like this.
Velpo is going from top to bottom, but
Yeah.
the
It
chest
seems
comes
like a
to the-
Bernard Shaw view.
Okay.
Yeah?
Bernard view is like this.
Yeah.
Bernard view is like
Here
this.
the arm is not moved. And I've got that as a protocol in mind. It's
Okay.
worked very well.
Interesting.
Look for STRIPP.
Looks good.
That's the guy.
Shekhar, why 1 centimeter?
Why 1
The drill
centimeter?
hole?
Which one?
1 centimeter from the AC joint.
From the AC joint?
The drill hole on the clavicle.
Yeah, we have to see the attachment of the CC ligaments. So it's almost 1 to 1.5 centimeter from the AC
Okay.
joint.
Where do you make your holes for the AC bond?
You are talking to me?
Yeah.
No, I didn't understand the
No.
question.
Where should the clavicle hole be made?
You mean in the AC?
For
In AC joint
dislocation.
reconstruction.
Yeah, what I do is I only pass subcoracoid sutures. So I pass them and then I put them to posterior and I see where are they touching the clavicle. So at that point I make a mark with electrocautery and you must have by the American studies at least 1.2 centimeters between the holes not to have a fracture. So this is how I do. My only comment is that humbly speaking I only think that mumford you did in the last slide was a little bit too big.
Which
yeah,
one?
yeah, it
The-
was like maybe 2 centimeters. You
8 mm.
you don't need that much. What you need is to do a Mumford for
Okay.
sure to avoid late
Yeah,
post-traumatic AC joint arthritis. But 2 centimeters,
So-
in my opinion, is too much. Do you agree?
That one for Weaverden, yeah, that
Yeah.
was slightly more than that.
Taking
Yeah.
too much off the clavicle.
Too much off.
You're going to destabilize the superior ligaments as well.
Sure.
And the anterior-posterior stability is lost.
Yes.
And that can also.
Absolutely, that causes more symptoms. But
And the other thing with 1 centimeter is that till 1 centimeter you have cancellous bone. You know that from when you're exercising the lateral and the clavicle.
no. My point was anatomical. We take our holes 35 mm because the trapezoid is attached 25 mm from the AC joint. The conoid is attached 45 mm medial to the AC joint. So because we do only single hole, we take it at 35 mm. If you're doing 2 holes, then you need one at 25, one at 45. Then you're anatomical.
Okay.
This is Grassi's study.
No,
Okay.
that may be right, but when you're doing it for a chronic.
Doesn't
case-
matter.
No,
You want
yes.
to replicate anatomy.
No, what I'm trying to say is that if it is a chronic case, the loading on the lateral clavicle is reduced, so the bone is very soft.
You are worried about fractures because you are doing a structural synthetic graft.
Yes.
When you do
But
a
it is a problem.
biological graft, then there's never a problem.
He's not
But
putting a graft there.
the weight transmission has to happen anatomically. Whenever you do a non-anatomical fixation, especially a non-biological, you are more at risk for fractures because you're loading the clavicle illogically.
So what is the
That-
current status on putting the graft along with this in chronic, how many,
In
what-
chronic cases?
in chronic cases? Are people still
No,
without putting the graft?
in chronic cases, simply doing tightrope is not doing anything. It works in acute case because there you are just reducing the joint, you are maintaining the distance between the coracoid and the clavicle, and you're hoping for the CC ligament to heal.
Yes, that's what I
Yes.
said yesterday.
Yeah.
You still have biological
Yeah.
potential for them to heal.
That's the
Yeah.
message I
Two,
think.
3
But
months.
in chronic cases, that healing potential is lost.
Yes.
So
In
just
acute
doing a,
cases, you can do
yes, and in that case, if you are just doing tightrope, then it doesn't work. We have to do some biological thing.
Actually, tightrope works very well when you have a lateral clavicle. Because the bone heals.
Oh, okay.
Lateral, yeah, if there's a fracture, yeah.
So if you,
But you don't need the title. Just fix the bone.
but if you look at the paper from Robinson from Edinburgh, he's done open endo-button technique instead of
Yeah.
using ethicone. He used endo-button technique. One thing he's noticed in that is that he does an open reduction of the clavicle fracture. The amount of periosteal interposition you get in the fracture site is much more. It's a bit like your medial malleolus fracture. That's why he says opening it up, clearing it up, reducing it and fixing it. Either with a suture like this or putting a suture between your coracoid and
We have done that, Nandan, for non-union lateral ends. What happens is the non-union lateral ends are dicey fractures. You've got only little meat on the bone and it's osteoporotic. You do
Yes.
any device, it doesn't work.
Yes.
So we do a tendon graft for that, ignore the lateral fragment, heals, doesn't matter. Functionally is back to normal.
Because
What you
you-
So
can
in
do-
fact-
what you can do as well is you use the same suture technique because it's absorbable. DDS cord is absorbable. You go between the acromial and the medial medial fragment, so you ignore the inner fragment, and this usually heals because you bypass that, and because it's absorbable, it will disappear afterwards, and that's it.
So sometimes we use a Mercelin tape. So So that's my recommendation, Sergio, that Ethibond is too sharp, thin, small, loading. Muslin tape is broad.
No, but I use H-Ball 5.
5, yeah.
No, also there is a slide, another notification, one of my bosses I have seen in UK, he was doing a pleating using 3 ethibonds those days, and that gave you a much broader thing.
The tape is still flatter, it distributes the forces, so less likely to cut.
In fact, that Vivod and Prosider was done for fracture lateral end only. It was a chronic fracture lateral end of fracture, and it was ununited around 4-5 months back.
Okay.
And that end was getting up. So we had to remove that. We couldn't find any bone to fix.
Yes.
So we just removed it. That's why you saw that so much of gap.
We'll go on to the panel discussion next. Thank you
Yeah,
very much.
thank you.
It was a very stimulating discussion.
Video?
Oh, you have a video to present?
Not to bypass.
Sorry, I didn't know that.
I'm just hoping there's less work to do actually.
Actually, you're not talking about biology. Why can't you use the conjoint tendon?
Interesting, it's been described.
It's been
If you,
papered from China.
there's a paper, but if you look where the conjoint tendon inserts on the coracoid, it's at the tip of the coracoid.
Yeah.
Again, non-anatomical. You want anatomy? I've been through all that.
Then one of the-
It was described by Steve Copeland many years ago, 30 years ago.
Why did you not continue? I've done one.
Right, so thank you, Amit, for this invite and very interesting. We've got a good cross-fertilization of ideas. But Amit, to be fair enough, called me on Sunday and said, you've got to do GT fixations. And I'd just done the 10-kilometer run. I was just pooped. So on my flight back, I opened up and did everything. And when I landed up, I realized it's a video session. Then the editing became just too long. So I've just put in few videos, so it's not a real edit. But this is like a photo essay rather than didactic talk and lectures and things. So I think Sergio spoke and I completely endorse his idea. GT fractures give me a lot of grief. And the kind of results we give, I'm not consistent with GT fractures because you do the best fixation, patients still struggling to get their movements through, and these are real dicey fractures. The first issue is that this is a young gentleman, had a fracture, clinically tender. This X-ray was done elsewhere, came back to us a week later with pain. This is the same patient, you do a true AP and you see the difference. So please do true APs, do axials, whenever in doubt, just ask for a CT scan. There is no harm done. But I have a series of missed GT fractures and that can itself go in as a presentation, and it's strange how that happens. When a GT fracture is neglected, it goes resorbation. It just dissolves because the concept, the theory I have is that it just loses its vascularity. The tendon being avascular, it doesn't get its blood supply. So a lot of GT fractures, they shrink or they just go and disappear like this gentleman here. And then we had to do a cuff repair for him with little fragments and insert those in whatever little bone is remaining there. So that's an alternative, but it's a poor alternative. A GT fracture would have been much easier to fix. So coming to this case study of a 31-year-old male GT fracture, again, this was treated by in a orthopedic hospital, and they just decided to conserve it. They thought this was in good position, but this just wasn't. There are two big fragments there, fierce subluxation, not a good sign, suggestive of huge hemarthrosis. He came to us after 6 weeks, and you see, there's nothing there. The young guy, 31 years old, IT professional, and disability. He just couldn't lift his arm up completely, behaving like a cuff tear. So it's only recently that I have started doing arthroscopic GT repairs. Honestly, no big advantage over doing an open GT repair. It's just a little more fancy. It's a little bit of more challenge, so I like it. That's why I do it as such. So hopefully this is going to work. Yeah. So I eliminate the first one. It's just like doing another cuff repair. You pass your sutures through the tendon rather than the bone. Don't touch the bone. You just need to freshen it with the shaver, because if you don't, that whole bone is sclerosed and smoothed out. This is a Versalock. After all the sutures have gone in there, the Versalock goes in the far lateral. You can see that there is no good cortex there. This is cancellous bone here where the defect was. So you just pick it up. There are subtle tips and tricks that I will show you on the X-rays later on where to put the Versalock anchor. That's a little different from your double O repair. once you've got this in, you need a good quality lateral row anchor. Some of the lateral row anchors do not have the purchase quality as the good ones, because if that's not there, you will see it come off right in front of you as you tighten the sutures, and the anchor just backs off because you are now in a cancellous bed. And these are sutures you can tighten up, and you can see that the cuff is completely plastered to the edge with flakes of bone there. So even if you're doing a fresh one, that will still pull the fragment in and put it down here. But when you're doing a fresh GT, we mentioned this yesterday, you must always do a double row. You cannot give a choice of a single row, because otherwise that fragment will be lifted off. And that's a real strong repair that you can see that on movement, it's moving as a unit with the muscle and the bone moving at the same isometric speed. So that is what works on these. Whether you need to use one lateral row or two lateral row, again depends on the size of the defect. So if you have a big defect, use two lateral row anchors. If you have a one smaller defect, reasonable one like this, you can just do one double row anchor. I usually do not use the pump for all my arthroscopic repairs. But when it comes to fresh fractures like this, I am compelled to use the pump, because it's bleeding tissue, you're dealing with bone, it's not the same. So this is where the anchor inserters come off. You can cut off these sutures, and then once you've done this, you've cut them off, you actually put the arm through good motion to know that you've done a good firm repair as such. The sutures there should be nicely equally distributed, so they're not riding on each other, because you want a uniform load distribution on these. And then you'll see that moving it across nicely, moves as a unit. It is a little bit more tedious than the cuff, because it tends to bleed more, the tissues are poor, the bone quality is poor, so you need to be absolutely on the ball with these fractures. And then once I've finished the glenohumeral part, you again go through the glenohumeral joint. So there was this long head of biceps tear he had, so we just debrided that nicely. This is the glenoid, this is the head of the humerus, and you see what kind of, this is the subscap coming in here, and you see that is the repair. So moment the cartilage finishes, you must see your cuff start off or the fragment there. You must not see the footprint. If you see in the footprint, then a medial anchor has not been placed appropriately, then you know that this is going to work. Now the suggestion here was, this is the post-op X-ray. You can see this double row anchor. These go right into the defect, unlike your arthroscopic cuff repair. This is another patient. This is a fresh fracture that we've done, unlike this one. This is the immediate post-op X-ray, and this is, you can see it, the fragments have healed beautifully after 6 weeks. If you see that anchor, the lateral row, it's right below the defect. Rather than normally in rotator cuffs, you'll put it as lower down as possible, but here you need to bridge the defect on the top end and bottom end, because then the bone is contacting firmly. The longer lever arm you have, the bone will not mate firmly with its bed. Now of course do a lateral as well. So they tend to do well. It's minimal invasive. Just to digress a little, we spoke about yesterday, I thought I'll show you this X-ray. 74-year-old lady, she had a GT fracture there, it was conserved, healed well, but she failed to generate her movement. Almost 6 months passed through, she was treated elsewhere, and she just couldn't get her movement through. And sometimes when that happens, and when you see the clinical picture disproportionately worse than the actual X-ray picture, this is what happens, that you have a big fragment there and it's just not doing anything. You treat it as a rotator cuff repair, because GT fractures in young and elder will behave much too differently. Be careful. Just finish off carefully that sometimes you are looking in the wrong direction. So do be careful. This is just one little case scenario I'll present. 19-year-old guy, GT fracture, he was missed. So a young orthopedics and shoulder surgeon from Pune met me at a meeting and said, I have got a 19-year-old guy with a full thickness cuff tear, what should I do? So I told him, listen son, there is no rotator cuff tear. And he says, no, he has a complete drop arm, and I am going to do a repair, so can you give me any tips, because he has a complete drop arm. I said, please go and look, there must be a neurological injury. Young people do not get, no, he's had a bad RTA, I'm convinced. This patient landed up at my clinic 3 weeks later. He did not get the operation done, and we looked at him clinically, sure he had a drop arm. What the surgeon missed was this, because that orthogonal view was not done. In the knee, in the hip, in the ankle, we take epilateral X-rays. Why do we not do 2 X-rays in the shoulder? And I can give you an elaborate lecture on how many cases have been missed. The fragment is still there. It's just been masked.
So everything went well, and he saw clinically, he'd made the diagnosis, he should have found out where the thing had failed. So unfortunately, by the time he comes to take that decision, that's Apple, by the way, Shashank. Thank you. Just do a CT scan. Whenever you are in doubt, get a CT scan, no harm. This becomes very difficult to treat at 6 weeks. Big fragment there, big fragment there. So that's what we've done. We've done just suture anchors because it's a fragile fragment, and he's done well. But
Open or arthroscopic?
this one is open, this one's open. At that big fragment, I wouldn't do arthroscopic at all. Just to open, that works well. He's had a bad review, and at 6 weeks, it's whole gone posteriorly. It's going to be very difficult to fish such a big fragment. So big fragment.
Reasonably difficult, even open.
Even open,
Even open.
but don't put screws in.
Even open. Huh?
Don't put screws in. Use suture anchors. Mid-lateral, split deltoid. Split deltoid. I usually take the split deltoid a little posterior rather than middle, because the whole fragment in all cases has gone
Yeah,
posteriorly.
And one message to the audience, because I deal a lot with chronic cases like this, is that in my opinion, and in many shoulder surgeons' opinion, the deltopack is a very bad approach to
For GT fractures, yes. Yeah.
very bad. So
Yeah.
I use the anterolateral
Yeah.
or even the lateral,
Yeah.
and I have never had
Absolutely.
in my life any problems with the axillary nerve.
No, it's not a problem or axillary nerve at all.
Because many people
No.
say, oh my God.
No,
yes,
no,
no,
no.
not,
Split deltoid. Split deltoid, yeah, yeah.
But no problems with the
Yeah.
axillary nerve.
Yeah. Do I get goodies? On time? Thank you.
Right then. Yes,
So we can let Shashank sit there, please.
yes.
We'll invite Oppo and Sergio as well.
Chalega. Right then. Basically, this is going to be a sum up of everything that you have done in the last few hours and the day before. We are starting with a 28-year-old gentleman with a fractured midshaft of clavicle. We have talked a lot about that. Yes, gentlemen. What would be your take on that? Shashank? What do you think you would do?
Young man, fractured clavicle, middle third.
Mhm.
I never knew about that 45-degree angle view, but now I'm wiser.
Mhm.
Yes, I would like to get a 45-degree view, but usually till now I never took it.
Well, this was not this man. This is not my case. That man was not as wise as you. Also, it was not taken. Yes, you please.
Skin, everything compound,
No compound things.
and
It's
no denting.
no nothing.
It's an isolated injury.
It's an isolated injury.
Conservatively.
Mhm. Yes, Avi?
I will discuss with the patient the two options, the viable options, either conservative or surgical. But one thing I want to say, that conservative treatment, it's not what people tend to think. It's not, send and forget. It's you have to see him every week. You have to tighten the figure of 8. You have to make sure that he is in good position. It's sometimes more difficult than to put a plate and
But you are not worried about this overlap, are you?
it's not. It's borderline. It is
Okay.
borderline.
That's interesting. One
So-
question I want to, can I ask Gopher?
Yeah.
What does tightening of figure of 8 does?
Yeah.
That's positioning.
It was talked about yesterday that a figure of 8 is mandatory.
Okay.
So what does it really do in this?
What would
Yeah.
figure of 8
Brace
do?
or figure eight doesn't matter.
Can I-
Clavicle brace
Keep it tight.
Can I just make a
Yeah.
comment?
Shoulders pulled back.
Well, and I'm sorry, we had a discussion in Ahmedabad 1 week ago about this, and I was telling to them that I have completely abandoned the figure of 8 because of, I have seen so many skin problems.
Many people
and
have.
some pulses I have seen, obviously they were transitory, and I have read some thrombosis, deep venous thrombosis, and I believe exactly what Sarmiento says, the old Sarmiento, about the tibia fractures. The tibia fracture will have a shortening caused by the fracture itself and no more than this. So or you accept it or you operate it. So I just put these patients in a sling, and and I believe that healing has nothing to do with the figure of 8. And I have seen some guys in Brazil, some old guys, much more older than Levi.
That's unfair.
Tell me that they have completely abandoned the figure of eight.
The figure of eight, I mean, the thing is that when you put a patient which is painful with a fracture in a sling, he tends to do that. And when he tends to do that, it's not only that he contracts further, he actually
He's causing
is
more
causing
overlap.
more
He's
overlap.
causing more overlap.
Yeah, the figure of eight does not bring it to normal, but it keeps the position of the shoulders like that, that you'll have a better healing in a better position. So that's, of course, it's not simple. That's what I was saying. It's not simple, just sell and forget. It's not simple.
Skin problems.
You have to check the patient every week. You have to tell the patient about the tinglings and the pins and needles, and to do, if this happens, to release it a bit and to do some pendular exercises. I mean, I'm not saying it's completely, problem free, but I think it's better to get the patient in this position.
My
Well,
question is
plus-
that,
yeah, Amit,
with a clavicle brace or a figure of eight, you get an X-ray before and after. Is there any better?
No difference.
Cities which are compared
Well,
to-
plus one more problem in our country with figure of eight is because it's a hot country, sweating and makes people all the more uncomfortable. But what we must not forget is the elbow support that we feel is more important for these patients with fracture clavicle than whether you use a figure of eight or not. This gentleman was treated in that, and 2 years down the line, it has healed completely. So, it healed completely. This is not his picture. This is something I've taken from somebody else. This is one of such combined healed fracture, which has healed with a bony prominence about that. Not that he's unhappy about that, but he's just showing that, well, it's still there. So, it happens. We
Or
know.
this, or a scar
Yeah.
because of a surgery.
Either a scar or a bump.
Yeah, a scar or a bump.
Or
Yes.
neuroma.
Or a
Well, there you are.
It's not uncommon.
This is not uncommon. This is a similar almost thing. This was fixed by this thing, and this lady, she was all. Everything is healed. Everything is nice, but it's painful because of this. Going to talk about.
Because IOACON from Singapore actually takes the whole sleeve, dissects the 3 cluneal nerves, and takes the flap off, and then puts the plate.
Yeah.
And I tried doing that in 2 days, and I just couldn't find. I said, "This, I
Plastic
don't have the
surgery,
patience."
orthopedic surgery.
No.
I have done that.
It's a nerve surgery. It's a nerve. It's a
Yeah.
micro.
Other than other problems of fixation, this local pain is one cause of concern. This lady, she is not happy, complaining of pain. There is a trigger point sort of thing there. Yeah, that's the point Ashish has just mentioned. Right, but if we slightly move more laterally, what about this? A 8 years old vegetable seller with a fractured lateral end of clavicle looks almost. Shashank, what will you do about this?
This is a difficult fracture to treat. Yeah, it can. I know that the ligaments, the coracoclavicular ligaments are broken. This needs fixation.
Not broken. That's what I'm going to say.
Just a fragment.
That's the
But yeah, that's- sorry.
the common mistake is
Yeah.
that people think that this is like AC joint.
Mm.
It's not an AC joint separation.
Here, yeah.
I would like to treat it like a AC joint separation, fix it with a hook plate or some device where I can get the clavicle error. Because I know this will behave like a AC joint disruption.
Well, this is still.
It's a completely different fracture.
Yeah.
clavicle.
Exactly.
So must be fixed.
That
Must be fixed.
No.
The distal end of the clavicle fracture, it's got very high rate of non-union
Yes.
because there is a compulsory rotational movement through the AC joint. And when you have this fracture, which is close to the AC joint, the forces will go through the fracture. So it will not unite in most of the cases. The difference between that and AC joint separation is that the ligaments are intact here.
Yes.
What you need to do is to bring the proximal fragment.
We'll talk about
to
that
the
in a
distal
minute.
fragment, and this will heal. So you don't have to go to the CC ligament because they are intact.
Well,
If you get them together, they will heal, and that's why I'm describing
Well,
this
that's
as a
exactly
technique.
that's exactly what Neer's classification is about. All these things.
Yes.
The grade 1 where it is lateral to the coracoclavicular ligament, grade 2 is when it's medial or in through the thing,
No, grade 2 is through the thing.
through or medial, and grade 3 is going into the AC joint itself. So for grade 3 and grade 1, you may be right treating it non-operatively, but if it is grade 2, which has damaged the coracoclavicular ligament, then then you have to fix it.
Surgically.
This gentleman, this happened to him about 2 years ago. He was treated conservatively, and he came to us 2 years down the line with this.
This osteolysis thing is catching up.
This is catching up, and this is without a plate. So, what do you do about that? And also, he's complaining of number 1, pain. Number 2, there is weakness. Not exactly, but he doesn't have enough strength on his arm. But this is the left side, and there is also a prominence. There you are. You can see it there.
Now it's like the AC joint.
Now it-
AC joint dislocation.
No signs of infection?
No. It's treated closed.
No, but there's no infection
Yeah.
there because
No.
this disappearance of bone is a bit
Why
worrying.
this?
That's the question. That's the question.
Huge waste.
And the huge amount of wasting there. You can see that.
Yeah, which is in the supra and in the
Yeah.
infra.
So why do you do that?
It may not come from the fracture side. We are presuming that because of the fracture, because there's no proximal migration of the medial fragment. He must have a rotator cuff weakness.
But I mean, this amount of absorption.
You mean another?
Yeah, strange.
It's difficult.
That's,
And wasting.
I mean, I would work very hard to exclude infection.
Yeah, I would think about infection,
Well-
or just ruling out some infection, because infection could reasonably explain the osteolysis.
True, but he never had any invasion into the fracture.
Fever, no nothing.
No fever, no
I think
nothing.
the skin was not breached.
The skin was not breached. It was not touched.
Okay.
Basically, he was treated by local bone setter, as it happens, and he was happy. He knew a fracture. He was happy. Only thing.
How's the moment
Shows
of
the next slide. The clinical side. I'm not saying show.
Fair. Next case.
Don't reverse. No.
What
This-
is the patient?
this-
What is the patient's
Look
complaint?
at the wasting.
Both pain,
Yes.
both so-called weakness, and also this prominence
This
is
guy, I
grumbling.
think seems, if I can see it from here,
And-
it's asymmetry of his trapezius as well.
There's a neurological.
He's got a neurological problem.
And
Yeah.
that is a possibility we have been thinking, but also he asked me another very significant question. He said that over last 6 months, it is, when he is feeling it is getting slightly worse. So he also asked, is it going to get further worse over the years before?
You mean 1 year he was fine and after 6 months?
It is
he
a,
had problem?
no, it is 2 years old thing.
That's what-
Initial fracture was happened, then he was sort of fine.
So 1.5 years he was fine.
He was fine, that is what he said.
De novo problem. De novo problem.
But I mean, I could not explain why he had this so much of resorption at the end. I don't
Yeah.
know.
But maybe a neuroconductive study done by a nice guy could help you.
Where do you get a nice guy to do a good clinical study?
Okay.
Not in
India.
Brazil, not in India. The way you be
Right.
going on.
São Paulo Medica.
One final question on that. Supposing neurological problems excluded, is anybody willing to fix this clavicle? No.
Not before we know
We
what's
understand
going on.
what's going on.
Okay, so that's a taking thing, that in such a thing which has come late with so much of resorption, which is not very common in fractures treated non-operatively, you have to think of other possibilities. But if it was seen on day one, we know that this would have been treated without operation, as most of us has agreed, not everybody,
I wanted
not
to-
everybody,
I
you know.
wanted to fix it.
Yeah.
I
Oh, you wanted to fix
right
it?
on the fir- Yeah.
Okay, fair enough.
You
And
have
sir,
to fix it.
I
Otherwise
wanted
you
to
have.
fix it right on the first.
because this was not really a type 2 thing. This was almost, almost.
The first X-ray.
We'll see.
This is type 2.
Is it?
Tendency to non-union.
See, Debashish, all lateral and clavicle fractures are dicey, so you must not treat them like clavicle fracture. But Rockwood's classification is different. There are 6 types. So the type 3, A and B, where the fractures between the conoid trapezium. Type 3B is medial to the conoid trapezoid. That's not the issue here, because there's a oblique fracture and it's like combination there, there's a high chance of a non-union there.
Fair enough. And then how do you like to fix it?
I would do the figure of 8 with a PDS cord.
Thick.
Very simple procedure.
We have
That's
talked about it.
I have faith in two devices.
Yes.
One is the hook plate,
Yes.
and the other is the contoured clavicle plate by AO, which has 2.7 screws to go in at least 3 or 4
In
lateral
the
fragments.
top part.
Yeah,
They are locked screws.
yeah, they're locking screws. Just to
The,
put a
the,
progressive.
Tell
the
us-
hook plate you'll have to remove.
Yeah, I agree. We talked to them.
What about the pain that you're talking about following this hook plate thing? There is impingement
If you
and
leave the plate in,
yeah.
6 months.
But
later,
even-
remove it.
The last case, we will not have a solution by now.
No, no. We don't have a solution. That's what we say. Red herring, because at this point of time, we don't know why he's having this osteolysis or resorption. Yes, this is a different thing where you have fixed a thing with a hook plate, and hook plates, as you all know, once you have removed the implant, at times there will be osteolysis either here in the subacromial space or here, or if it is not done properly, then it can still cause trouble like this.
When was that removed?
This is not my case, I would not know.
But we don't know.
No, I don't know.
The recommendation is 6 months. Don't wait for longer because it can dig into the acromia.
This is something here also, I can see, I don't know. But this is immediate post-op, everything looks fine.
Yeah.
There is resorption of the lateral end also, and there is something underneath there also. So this is not fair. And,
Can I just make a very short comment?
Yeah.
In World Shoulder Congress 2010,
so, it is coming down a bit more, yes, agreed.
It should sit under the acromion only, then it can provide that hooking. Otherwise,
Maybe,
I
yeah.
just want to make a short comment. There is a Japanese guy that made a paper that he made an arthroscopy immediately after the removal of the plates. And he showed the paper in World Shoulder Congress 2010. And the number of rotator cuff bursal lesions was, I guess, 30 or 40%.
Yes, that is exactly
And you
the-
could see as looking to the ceiling, looking to the acromion, a black spot and a very ugly metallosis. So this is something that we think in Brazil. I'm not a trauma surgeon. I'm a shoulder surgeon that does a lot with trauma. That this is quite dangerous to the shoulder.
But the
Not
metallosis
not
I
initially.
accept.
Yes.
Metallosis I accept.
Yes.
The blade goes 90 degrees behind and laterally. So it cannot cause impingement or
Yes.
problems. It is
Yes.
not involving the anterior 2/3 of the acromion.
The main problem of this plate is that it blocks the obligatory rotational movement of the AC joint.
Yes, that is absolutely the thing.
That's why you have to remove it.
Absolutely.
But again,
Because,
I've
as
removed
you have
both
said-
these. I don't like to use these plates, and I removed many of these plates, causing a lot of trouble.
They must be removed.
they have
If you keep it in,
Yeah,
then
that
Will
will
have
be
trouble.
finding disaster,
So
yes.
Yeah, no,
when
Yes.
a patient is given the plate, we tell them 6
Yes.
months and we need to remove it.
Yes.
So anybody who doesn't come up, then he's not following the guidelines.
Same thing. The same thing as happening with Bosworth also, because the clavicle doesn't move only up and down or anterior posterior, but it also rotates. That's why the Bosworth screw also breaks, and that's why this plate going under the acromion is also not proper.
There's a famous saying for that.
Anybody having-
breaking
Anybody having experience about this tension band wearing with KOS for these?
no.
Revision.
Yeah, I have to revise a few of those.
Yes, removal. The problem is pins coming out, they are causing subcutaneous problems,
And
everything.
It's joint,
When you block the AC joint, you
Yes.
destroy the AC
yeah,
joint
Agreed.
as well.
it's a joint arthritis.
So, but basically what we are coming to that lateral end fractures, the plate is not all hunky-dory. The tension band wiring using K-wires has got its limitations, and still the suture fixations and these other fixations are much better than possibly using metal implant. Is everybody agree to that, more or less? Right. Now we are coming to our third problem. The fracture shaft humerus, convoluted, proximal, what do you do? Okay. No plating guy here.
No, I'm not leading up.
Mm-hmm.
Well,
Yes.
everybody in India,
Yes, please.
in India or knows that in the last 4 years, I've been showing so many cases of anterior bridge plating. Probably I'm doing a PhD in the next year, where I have done more than 60 cases of anterior bridge plating with one non-union and one infection over 5 years.
No.
So in my case, anterior bridge plating, absolutely no doubt. Not plating, anterior
Bridge plating. Yeah. Shashank? Yes, I don't do also these cases. Yes. You, sir?
I would prefer in these cases to use nail because it's less invasive, less
True.
traumatic. Close, yes. But sometimes when it's a condition like that, and if there is any question about the nerve, I would do plating.
Yeah.
solve the nerve.
I think that is sensible because of the comminution and because the patient was rather elderly. So the surgeon here decided to do a nailing. It was still not very perfectly reduced. There was still the jutting out of the lateral fragments, everything. But it healed in that position reasonably well. And this also ensured reasonably good range of movement for the lady. So yes, that is definitely, yeah. But can I ask you, I mean, Sergio, you said you do anterior bridge plating.
Yes.
And there is, as you said, there is minimal or no non-union things. What about?
One case over more than 60?
Yeah, that's minimal. What about the range of movement for your patients?
Absolutely fantastic. I've got all my videos here if you want to see. I allow them to move the day after the surgery, but they can never carry weights. Just elbow motion and the shoulder about 90 and no problems.
Do you use any support?
No.
No.
No, and all my residents are told to put them to move. In spite of being very poor people, the majority of them, they have a lot of discipline. So I put them to move.
That's a big incision or too big incision?
Huh?
Too big
Sorry,
incision?
shoulder.
No,
If it is
small
too proximal like
incisions,
this,
3 centimeters.
If it is that
incision,
proximal.
I